And now we're going to get the rest of today started with our first speaker. I'd like to introduce Tim Beams. So Tim is the lead physiotherapist at Pain and Performance, a NOI UK clinic, and he has a special interest in treatment of people suffering with complex and persistent pain states. He's the co-author of the Graded Motor Imagery Handbook, alongside Lorimer Mosley, David Butler, and Tom Giles, and the chapter on, does that sound squeaky a little bit? On the chapter on management of cervical spine disorders in the 8th edition of Maitland's Vertebral Manipulation in 2013. A little bit more about Tim, a little more personal, is that he's a lover of wine, trainers, and decent coffee. And also, he has started an international phenomenon called Le Pub Scientifique. It's in London, it's in Amsterdam, and I get to speak there April. So he's taking the conversations to the pub where the best conversations tend to happen. So there might be a little one today too, who knows. But anyway, I'd like to bring Tim up.
Awesome. Just give me 2 seconds. I get to introduce Sarah then in April. You were quite kind to me there, weren't you? I'm not sure whether it will be reciprocated or not after I've had a drink. Try again. Yay. Wait for it, there'll be another one as well, won't there? Oh no, it works. So I suppose you're all wondering, do I use shampoo or do I use shower gel? But sometimes shampoo. Depends. You can double up on that, can't you? So I'm going to talk today about something I'm quite passionate about, which is body perception. I've given us a sort of loose title, a loose definition. My experience of my body is what I say it is. And I've given the validated by science. Ooh. I'm not using anything at the moment. Let's try. And some of you will have heard that I hadn't written my talk last night. There's nothing like preparation. And it's not because I'm totally disorganized or that I was made to go and drink lots of red wine or anything like that. It was more because yesterday there was some fantastic threads coming through the discussions and the talks. So what I decided to do is just take some, and sorry Shana, I missed your talk so I couldn't use what you were saying. Maybe I can use the passion in my talk, and that will be what I've heard came from Shana's talk. But there were some common threads that I heard. One, that we need to allow the individual space to share their narrative, which I think is really, really important. What the person feels is important, validating their experience perhaps. Their expectations and the context in general matter. you can probably hear who these come from. Being kind to ourselves translates back to the person in pain. And pain is more than just what goes on in the brain. So what I decided to do was take my talk, my ideas about my title, and see whether we can weave a common thread from yesterday into my talk. So I'm going to just start with the first person phenomenological experience. Now that's difficult to say in the evening, a little bit easier now, but the narrative, the journey of that person in pain. And Maxi yesterday gave us a couple of, I thought, really tremendous ideas. Being open, make room for the story. And for those of you who listen carefully, open your ears and shut your mouth a little bit. I mean, we really do hear some tremendous stories, don't we? The narrative that they offer us. It can be quite upsetting as well at times. But it's important to give them time. And my experience of someone who has persistent pain is that they probably need a little bit more time as well to offer their story back to you, to be able to open up and get comfortable as well within that space, which takes a huge amount of consideration, care, and also practice as well. What Karen told us is pain is what you say it is. We do a couple of different exercises on various courses discussing what we think pain is. And it's a subjective experience. It's something we can never truly understand what that person is experiencing. It's inside of them. It's their first person experience. We try and measure a pain experience, and we can do that on subjective scales. We can try and quantify those scales as well, can't we? And we were listening to Karen talking about biomarkers, and I thought it was really interesting how she was saying, you know what, we need to be really careful about using these biomarkers as a diagnostic for pain. You said it was being temperamental. It's because I've fiddled around with stuff. So I was going to start with the first person. I've loosely called this selfhood. Selfhood is a constellation concept that involves not only representation and control of physiological homeostasis, but also the experience of owning and identifying with a particular body. So those of you who heard Antonio Damasio yesterday morning just started to touch on stasis, didn't he? And there's something interesting for me here is that there necessarily needs to be a body involved in the pain experience as well. So when you, and some of you were here on my class Tuesday and Wednesday, it seems absolutely ages ago now, doesn't it? We were pulling apart different pain models, and what we found from those pain models historically is that they were exploring pain but separating the person out from a pain experience. So going through historical models of pain, people were really interested in the tissues, but at the expense of the rest of the person. Then the attention started to move towards the spinal cord and the fact that we might be able to modulate sensory experiences. And then at the moment, we're in a sort of brain age. But what's interesting for me is we're just at a cusp now of saying, do you know what, maybe we're a bit more than that. So it was wonderful hearing Karen saying we're more than a brain, or pain is more than just what goes on in the brain. So I want you to just think, at the moment, how does your body feel? Before I said that, was anybody aware of a particular part of your body? And if you were aware of a particular part of the body, why was it that you were aware of that part of your body? And now that I've said, think about your body, can you stop thinking about your body? Put that out of your awareness. Stop it. Yeah. I've got a friend called Mick Thacker. He says, think about your left elbow. And now that I've said left elbow, inevitably our attention goes towards the left elbow, doesn't it? And if I was to say, stop thinking about the left elbow, just ingrains it, doesn't it, even more? But normally we can go about our lives and we don't have to think about our bodies, but we have that dynamic ability to take ourselves into our body and out again as well. to be embodied and disembodied. So essentially dynamically disembodied. We move through those states. Now I've got an interesting picture to show you, and this is a patient of mine drawing how she felt or viewed her body. So it would be a representation of body image, wouldn't it? I don't know whether you can see which side is the affected side or not. What I know you will struggle to do is to tell me the specific body area that she was suffering with pain, because we see it's a fascinating picture actually if we were to dissect it, but she's mirrored herself. She's actually viewing and drawing herself in the third person as if she's looking in a mirror. And the right-hand side of her body, it's her foot actually that was the painful area. But the whole right side of her body is affected. And what's interesting in that as well is that it even looks as though she's trying to look away from the right side of her body, almost as though she has completely disembodied, disowned perhaps, that side of her body. And if we were to reflect on that, if that's how your body felt to you, perhaps it's not surprising that you may experience pain. Yeah. We're going to touch a little bit on space and space-based processing later, but one thing Maxi said was about being careful, inviting yourself into their space, or make sure that you get invited into their space, and that you might see people sort of withdraw or retract. This is someone who's suffering with something called complex regional pain syndrome. And what we see with these people is that they become defensive in the whole space around their body. So as a clinician, even going into their space can be dangerous. And it's something that's been described to me that the part of their body that was affected felt so big, it was as if that person was in their body. And that sounds absolutely terrifying, doesn't it? Yeah. So I would absolutely agree with Maxi, make sure that you get permission before you come close, or even go towards the affected side for some people. Is anybody thinking about their body now? The left elbow, perhaps. I wanted to call the talk, "Does my bum look big in this?" But I was told that wasn't the sort of title that you give an American audience. So a first-person experience has been explored in a number of different pain states. My personal interest is complex regional pain syndrome. So here's a narrative review of people with CRPS. How often do you hear of someone telling you that they experience a distortion in perhaps the size, the weight, the temperature? It feels a bit cooler, it feels swollen. Is it bigger? They'll often ask you these questions. And it's something that perhaps you can't see. Visibly, there's no real difference, but it's certainly something that is salient for them. I had a really fascinating description from one man who said his bicep felt as though it was pumped up like an over-pumped bicycle wheel. And you just think, now that might be the case for the people. Where are the Norwegians here? Yeah, the big men in the room. That if you could get yourself pumped up, and that might be a good thing, but for this guy, it wasn't a normal thing, and it wasn't something that had come out of the gym work that he was doing. They can have hostile feelings towards themselves, towards the affected body part, a sense of disowning that body part. They don't necessarily know where it is in space. Haven't got time to really go into that in detail, but at the moment there's some really interesting work about exploring whether or not someone is aware of where they are in space, which has, huge implication on movement therapists, doesn't it? Offering them back some therapeutic movement. They can lose anatomical parts when they imagine themselves as well. So some of you might take people through body scans, for instance. So a simple body scan is a way of accessing an understanding of their body and the perception of their body. And sometimes people explain it's as though they've lost that body part. Maybe it's like there's a window where it should have been. And some people sadly have a desire to amputate, and I've seen a number of people now who have had and gone through an amputation process, and some people, unfortunately, who've had revisions and have had amputations on the contralateral side as well. And although I know there will be people out there who benefited from amputations, it's certainly in this population, it's not common. And I wanted to touch then on feelings, and there was a comment that Antonio Damasio said yesterday: feelings are the images of our inner world. I thought it was the best thing of his whole talk, actually. And he brought up this slide. There are fins in this room, aren't there? But what a beautiful demonstration of what they've called the subjective bodily feelings. So the study was, I think it was around 460 people who were asked to rate a number of different emotional, cognitive, sensory states, and also to draw where they felt those states within their body as well. And you can probably, if your eyesight is absolutely fantastic, which mine isn't on here, no, but at some point you can see things like anger, hate, hunger, toothache, loneliness, and things like that. So one thing Antonio Damasio said was about valence and the fact that it could be a positive or a negative valence, something that is emotionally interesting for us. A summary of this article from these authors, though, I find really fascinating. So our experience of initiating, executing and controlling thoughts and actions is a central tenet of human phenomenological experience. Agency binds our thoughts and actions to our ownership and could be the key dimension of subjective feelings. So agency is, essentially it's the authorship of your movement, is selfhood. So what they're saying is there necessarily is a link between your body, your sense of self, and the subjective feelings that you experience. So for some of you, you probably hear in the notion of embodied cognition here. The experience of our bodies is highly, highly dynamic. We're going to see a little video in a second, but I just want to introduce you to this concept just on the right-hand side. I've tried to add a body to what's called the mature organism model, and I'll mention the mature organism model in a little bit of detail. So a traditional model would be a computational model where we're fed information. There is an input through the senses that's then processed, scrutinized, and then as a result of that, there's some form of output. It pops out somewhere. Again, in our class, we discuss this in lots of detail. Louis Gifford's mature organism model has this beautiful circularity about it. So, yes, we're fed information, or we process, or we gather, or sample information in our environment. And that environment isn't just our tissues, it's our external environment as well. So you can probably start to hear, we could go somewhere with Shelley's talk as well. We sample, process that information in respect of the world that we understand, our beliefs, understanding, expectation, meaning, our background. I'm starting to think of Mark's talk now that might influence the response. He still uses the terms input, processing, output, but there's a circularity. Now, we don't necessarily need for, if it was a pain experience, the pain experience to start as a sensory input. It's a part of a process of being, of gathering all that information in relation to our understanding of our world. And that experience is necessarily tied intimately to that process. So body perception for me is a dynamic, multi-sensory integration of self-related signals and, importantly, open to change. We're not fixed. We are changeable. If we did think that we were fixed, we'd probably lose heart in our career, wouldn't we, quite quickly? But it's so often a message that your clients will come to you with, yeah? It's just old age. Oh no, it's not going to change, is it? So Karen, she was quite prescient, wasn't she? I thought her talk was absolutely fantastic yesterday. We probably needed an hour and a half to digest the talk in a little bit more detail, but she mentions essentially the model that I've just introduced here, but she's used slightly different terms, bottom up and top down. Now the important part of the difference in the mature organism model as I've introduced is that the flow of information gathered from our senses appears as though it's always in a bottom up from the outside in direction. What Karen's mentioned here is actually in parallel at the same time there is a flow in the opposite direction. So your thoughts, beliefs and understanding influence the sampling, the processing, the scrutinizing of the information from our environment. So if we were to take a step back and a step away from the models about pain that we've been fed in the past, the important caveat, the important change here is that there's a dynamic parallel processing of information of the person in their world. So here we are exploring, so I hope you don't mind, Jason. Odette, I have to say, she isn't standing up there. Okay? And Jason he's taken us through a rubber hand illusion with Amy. So I'm going to say a little bit about this in a second, but just have a look at the setup. So there's no way, I think you'd agree, that the rubber hand could be Amy's hand. Yes? But what she experienced, you'll have to take it from me, is that the touch that was on her real hand, but she was seeing happen at the same time on the rubber hand, was felt closer to the rubber hand. So there's what's called a proprioceptive drift of that experience. So for me, it's a beautiful illusory experiment to explore the dynamic nature of our bodies, and in particular, in this case, it's the body ownership. So there's something about we're taking on self-related signals. Now, in this case, we've obviously got visual information that we're dealing with. We're dealing with some kind of touch through the skin and the rubber hand at the same time. And there's knowledge about touch relating to our skin and seeing it happen at the same time, that the brain, if we can separate the brain out from the person, I'm not sure we can, gives a greater than probability chance that the touch that is being felt is occurring nearer to where it's being seen. Yes? So there's a shift then towards that rubber hand. She doesn't literally feel like the rubber hand is hers. And if she was to stand up, I didn't bring my rubber hand with me. I thought I'd done one joke too many, but it wouldn't be stuck to her, would it? But there's a flexibility to body ownership. And it's one illusory experiment that we can use to explore physiology and the dynamic nature of our physiology relating to body ownership and body perception. And here we have a really beautiful experiment, Lorimer, Alberto Gulace, Charles Spence. And what you see is, to begin with, a rubber hand illusion where they're doing an asynchronous touch paradigm. So they're not touching at the same time, it's happening at different times. So for that person to believe that the touch is happening at the rubber hand is impossible. It's incongruent then, isn't it? Touch and vision. Then they change over the touch to a synchronous paradigm, so they're seeing and they're feeling touch occurring at the same time. And what they've done is they've measured the temperature of the hand in a couple of different locations. And as that person falls into the illusion, as they start to drift, as they take ownership of the rubber hand, you see a drop in the temperature of the limb as well. So how beautiful that we see that. It's almost as though that person is saying, I no longer need to perfuse that limb that's not mine. We see that drop. And coming back to the CRPS patients, we heard about people having a sense of disowning their limb. And actually what we see in CRPS, there are two distinct phases that people talk about, a cold phase and a hot phase, or a warm phase. And we see significant changes in the limb temperature that may be linked to this shift in body perception and shift in body ownership. But we see shifts in physiology from a top-down perspective in respect of beliefs. And I had to put this up here because of Karen's talk, because as she carried on talking, I couldn't help but recognize numerous publications. She's really out there, isn't she, in her work? But there's a great guy called Tim Salomons who did quite a interesting experiment where they've created a paradigm of sensitization by giving noxious stimulus to an area on the forearm. And they give repetitive noxious stimulus. I think it's about 8 seconds, and it's something like 45 times they'll do this stimulus of the arm. And after that, they measure a number of different neurosensory measures. So they measure the experience of touch to light touch and to pinprick. Now, for those of you who know a little bit about your pain and pain science, light touch, if it was felt as painful, would be described as allodynia. Pinprick, if it was felt as more painful than normal, is described as hyperalgesia. And we have a zone, a flare zone of sensitization, where if you see an increase in perfusion, increase in blood flow, essentially an inflammatory response, that's considered to be the primary zone, so you would have primary hyperalgesia, for instance, in that zone. Anything outside of that zone, so deemed outside of the affected area, would be secondary hyperalgesia, and is thought to be as a result of central processes. Now, what he's done here is measure a change in the sensitization with a simple, short cognitive behavioral strategy focusing on pain for some people, and then I think it was active listening for the other group. And what you see is effectively that there is a difference in the pain experience after 8 sessions, but more importantly for me is that there's a significant reduction in the area of sensitization to the exact same stimulus. So their beliefs, I believe it was significantly correlated to a change in pain catastrophization. So their beliefs were significantly correlated with the extent of sensitization as a result of repetitive noxious stimulus. I just think, personally, I think this is cool stuff, that your top-down influences, your understanding, your beliefs in this case, have a direct effect on what's going on at the tissues as a result of experimental damage. Now, taking that into a clinical population, there's some beautiful work coming out of Australia. There's always beautiful work coming out of Australia, isn't there? And beautiful people as well. There are a couple of questionnaires, there's a couple of measures to be able to explore body perception, and this is one of them. It's the Fremantle Back Pain Awareness Questionnaire. And there's a couple of questions in here for people to answer. I can't perceive the exact outline of my back. We've just talked about that. My back feels as though it's enlarged or swollen. And what they found I can't remember how many people that they explored this with, but what they found was that the disrupted perceptual awareness of the back significantly and uniquely contributed to the pain intensity and disability. So the more the awareness of their back was disrupted, so the more that there was a change in body perception, the greater the pain intensity and the greater the disability. And interestingly, that there wasn't a significant effect of pain catastrophization. So coming back to my title, my experience of my body is what it is, or is what I say it is. How important is it for us to listen to that person's journey, listen to how they explain what they're experiencing? There's a number of other ways of exploring this, and I just wanted to show you one because we've got so many touch therapists here, but also during our class we did a little bit of science. Loose science, I would probably call it. So these are a couple of papers on exploring something called two-point discrimination. So two-point discrimination, we're going to see an example in a second, is where you ask someone to accurately discern whether or not you're touching them with 1 or 2 points. And the measure is the minimum distance that they can accurately tell you that they're being touched by 1 or 2 points. There are various different normative values. On the left-hand side, we've got a paper with a guy called Hannu Lomijoki and Lorimer Mosley, and what they've compared, people with persistent back pain have significant loss, so they're much worse at two-point discrimination, but at the same time they're losing voluntary movement, voluntary lumbar-pelvic movement as well. The opposite side paper is a paper by Nishigami and their group. What was interesting here is these are people with back pain. There's a control group. Some people with back pain don't feel as though there's a shift in their perception of their back. And if they don't feel there's a shift in the perception, they don't have a significant difference in their two-point discrimination values. But if they do feel that there's a difference, in particular, if they feel that it's enlarged, swollen, expanded, then there is a significant difference in their back. And I want to show you, this is a patient of mine who was really struggling understanding where his back was in space. If anybody's got a caliper, you could probably guess the length here. But the normative value for the lumbar spine around L3 in a horizontal direction is about 5 centimeters. So this is about 12 centimeters. We haven't got any sound, so he's going 1, 1, 1. At that distance, it's very difficult to create a synchronous touch of 2 points. But what you can probably guess is there is a significant disruption of his awareness of touch to his lumbar spine there. Now, I said we did some loose science, so thank you to Ben Boyd for this. I've cherry-picked the most, visually significant result from our experiment. So as a group, what we did is we did two-point discrimination to the first interosseous space. And we did it in 3 different conditions. We did it with the arm rested on the table. We did it with the arm behind the back, and there were some real difficulties here because we had a couple of big people, didn't we, Nikolai? Getting their hand behind the back was just difficult. So we had to wrestle their arms behind the back. And then the last condition was their hand next to their face. And what you see, you would expect as a touch, I think you would expect that the assessment of touch should be the same regardless of the position in space. Yeah, touch is generally thought of, and two-point discrimination generally thought of in regards to the innervation density of those tissues. But what we see clearly is there's not much difference whether they have the hand on their table or behind their back. There is a significant difference, though, when we put the hand near the face. And I'm going to show you this because this is just very, very cool stuff. And I see this as a loose link to Shelley's work yesterday. This group here, led by Gian Domenico Ionetti, we heard his name yesterday, were measuring something called the hand blink reflex. So they create a noxious stimulus of the hand and they measure the reflex of the ocular reflex. And a noxious stimulus generally creates a reflexive response. What we see is that if the arm is away from the face versus near the face,
the reflexive response is much, much higher when it's near the face. Now that's interesting in itself, and they talk about this in respect of something called the defensive peripersonal space. So I suppose the suggestion there, defensive, insinuates relative threat to that person, and be something that we could explore and talk about. But the concept of a peripersonal space is the space that we have affordance within. We can move around. That's interesting. What's even more interesting is that if you measure your blink reflex with your hand next to someone else's face, there is a larger response when it's next to someone else's face, particularly if you show signs of higher empathy. Now, how cool is that? So your physiology to something that's noxious, potentially dangerous or threatening, is influenced in space, but also with someone else in your space. I mean, it's, for me, so important as a therapist there. So I've just summarized what I would call embodied cognition. So here's a couple of pictures. For our group visited a lady of mine called Mary, and on the bottom picture you can clearly see it's a scintigraphy scan, so it's looking at the temperature of the limb, and you can probably see the right limb is at the foot blue, isn't it? So it looks like it's the same temperature as the external environment. So clearly there's a significant difference. And her foot above, if you really look at it, it doesn't look like a healthy foot. It's quite common with CRPS for them to have quite mottled skin. It looks a little bit swollen, looks a bit shiny. If you really look closely, the nails aren't in a good condition as well. There's ridges on the nails. And a little bit higher up her leg, we'd probably see things like significant hair growth as well. So cognition, it extends beyond the brain so that an ever-changing body is at the core of how our experiences are shaped. And we've brought in the body. Well, I think that's important. But not to forget, embedded refers to the situated interaction between the embodied being and the external environment in both place and time. So moving us forward and our understanding of pain forward, I believe it's important to put the body back into the picture, put the person back into the picture, but put the person in their world back into the picture. So coming back to Louis Gifford's mature organism model, and this is a sort of reflection from Mick Thacker about pain in relation to the mature organism model. It considers pain as a conscious event, describing the interplay and interconnectedness between the person and their environment via the body as a whole. Therefore, damage, threat, and stress affect the whole person. And we could probably add to that, are likely to also affect the people around them. Thank you very much.
All right, so are there questions in the room? All right, up here, who's my mic person? Up here to American Richard, as he's known now.
American Richard, as opposed to Canadian.
Oh, where's Canadian Richard? Tim, thank you. I feel selfish because I was in your workshop, so I could have asked this question then. But I think it's important. Being somebody
My
who...
answer might be just perhaps, mightn't it, as well? Maybe.
Maybe. So being someone who's been working on developing frameworks and being knowledgeable of these frameworks that we're working in, and now knowing, all of us improving our understanding of pain and perception, and these embedded and embodied models, we find ourselves now embedded in the lives of our patients. What frameworks have you ever explored, or could you explore for, what our new role is, and how does that affect what we do, who we think we are, how we think in the clinic. I feel like we have more knowledge now, we have more responsibility, but it's like, what do we do?
Thank you, Richard. Can I ask whether I have got this right? So is there a clinical model that would accurately be able to be used to incorporate what we're learning about here? Is that the question? You've got no way of qualifying it.
Just a fun model that you use to put yourself in society.
So what Richard said was a fun model to put yourself as a clinician into society. Beyond the models that we've talked about, and there are a number of others I guess we could have gone down. So inactivity is one of them, predictive processing we explored as well. There isn't one in particular that I would say I've definitively used and found really useful. Beyond a reflective practice. So reflecting, thinking, going through a metacognitive process. I was one of these geeks, I guess, who had a lot of travel time, so I did an awful lot of reading, but I also audited every one of my patients for a couple of years to see whether or not I was doing what I thought I was doing, and whether they went where I thought they would go as well, so I kept things like a prognosis. So I did a lot of critical thinking in my own practice. Yeah. I don't think that answers your question, but thank you. Yeah. Answered my own question. I would love someone to hold up a rubber hand.
Could you say, two questions, could you say a bit more about what the blink reflex is? You said it's stronger when the hand's next to the face, especially in empathy. And then my second question, I'll go ahead and mix that in. When two-point discrimination changes, does pain change?
Okay, I think it's an illegal maneuver, isn't it, having two questions? But thank you for that. I'll let it slide. Yeah, the blink reflex is just the reflexive action of the ocular muscles. So I'm guessing that it would be measured through maybe EMG activity. I'll have to look at the paper and to remember exactly. Two-point discrimination, whether or not it's linked to pain, I haven't suggested that. What I've suggested with what we've seen here is that a disruption in body perception and body awareness seems to be linked at the same time to a disruption in two-point discrimination for some, and also that might link with a disruption in their voluntary movements as well. I wonder whether you're putting knowledge, back when two-point discrimination seemed to be correlated with an improvement in pain state and an improvement in the activation of the primary somatosensory cortex. So there was a couple of people studying that area. I'm not really that confident in the results that came out from those studies. And there's a couple of different problems there. The region of interest and the measure, needed to be more than just the primary somatosensory cortex, for instance. Yeah. But we do see reports that as someone's pain improves, they have an improvement in measures like two-point discrimination. Yeah. Thanks.
Any other questions in the room or online? Nothing online?
They were their own hot tub, weren't they, last night?
This question is from Sherry Piancent. I'm working with CRPS patients. How do you balance their need to control their environment and the need for graded exposure?
How do you balance the need to, I missed that, the need to do what?
So how do you balance their need to control their environment and the need for graded exposure to encourage adaptation? We need to validate their experience yet push them as well to have them adapt.
Well, that's a really long one, isn't it? I mean, look, for some people don't need to control their environments, but it may be safer for them or helpful for them in a temporary way to create some form of constraints there. And we saw a picture of Mary just beforehand. One of the things we had to do with Mary was to accept that she needed to use a wheelchair to get around. I don't remember the last bit, but it made me start thinking about affordances and agency. And it's an interesting thing about pain that it's almost as though pain has agency over someone with persistent and severe pain states. So their possibilities in their life or the affordance that they have within their environment can be hugely limited. But as you offer something back to them, what I would say is that they grow in areas that you can't predict that they're growing. So their possibilities, what they're able to do, where they're able to do it, it can change in very different rates. But for me, it's about giving someone back health and well-being to them in many areas of their life. Again, I've no idea whether that was the question or not.
We have another online question from Brian Rutledge. Do you think it's possible to improve disruption of body image or self-perception by the intentional training of interoceptive skills, similar to the work of Cynthia Price?
Great question. The important thing is that I believe it's dynamic, so disruption would suggest that perhaps on the continuum it's not able to move fluidly or flexibly on the continuum. So, for instance, our example of being embodied and disembodied, perhaps that they are struggling to be dynamically disembodied at a stage. So, skills like building interoceptive awareness is or could be really helpful for some people, but there will be populations, so chronic fatigue, for instance, tends to be characterized by people who are already interoceptively very aware, so very interested in what's going on within their body. So I would say, like Karen was mentioning yesterday, it would be about treating the individual and understanding whether there is a relative phenotype for the states that we see.
Other questions in the room or online?
I got scared away.
No?
Too early.
Or it was just that good of a presentation.
Too early, yeah.
No questions. We get it. Okay, awesome. Well, then we'll start break a little bit early. We'll be back at 11:15 for the next speaker.